Welcome to the Proactive Security Podcast with Mike Hodges and Bryan Hamilton. This podcast is dedicated to discussing violence prevention in healthcare. We want to inform, equip, and empower healthcare security leaders to prevent violence before it happens. And now, here's your hosts, Mike and Brine.
Hey everybody, I'm Mike.
And I'm Bryan.
And this is episode 18 of the Proactive Security Podcast. We have a very special guest today with us, don't we, Bryan?
We do. We have the pleasure of being joined today by one of my favorite speakers, someone who I always learn a lot from every time he's sharing information, and that is none other than Bryan Warren. Bryan, thanks for joining us today.
Hey guys, how are you?
Well, very well. Why don't we start off, Bryan, by you kind of introducing yourself to our listeners and tell us a little bit about you and your history with healthcare security and get everybody acquainted.
Oh, sure. Yeah, I appreciate it, Mike. Thanks. So my name is Bryan Warren. I've been in healthcare security now. This will be my 34th year in a wide variety of roles. I left the day job, so to speak, retired in 2019, and I'm now focusing full-time on consulting, which is WARSEC security. In my time in healthcare security, I've seen a lot of changes, as you can imagine. You know, we're looking at, over 3 decades of everything from critical access hospitals to urban, large campuses to the home healthcare worker to, everything in between. And I've really been privileged to be a part of a lot of different associations and a lot of different folks getting together and task forces to try to make everything better. I think the last number of years, I would say probably the last 10 years or so, a lot of the focus has been more on workplace violence, particularly in just the last 5 years or so. But I think anyone that's been in the industry, either on the clinical or on the non-clinical patient care side, would agree that workplace violence has been an issue for much longer than that. But it's just being dramatically underreported. And we've all heard it before, but it's true. It's kind of a cliche, but a lot of people just thought of it as part of the job. And it's unfortunate because I think now we're finally starting to understand the importance of security in the healthcare environment, the value of security. And I think that's something that we've all had to discuss, not only at our own organizational level when it comes to validating resources and, making people understand what an investment of security is. It's not a cost, it's an investment. It is. And there's a huge difference between those two terms. And I would suggest for all security directors and practitioners to really study that, really understand the difference between a cost savings and a cost avoidance and value versus cost versus investment. But I also think that all of those practitioners out there are understanding that workplace violence can have a detrimental effect both tangibly and intangibly. In other words, it's not just the dollar amounts, it's not just the injuries, it's not just the losses to assets, but you're also looking at reputational loss, you're looking at turnover rates, you're looking at, litigation and indemnification. So I've seen a lot in the last 30 plus years. I think we've made a lot of good progress, but I'm really excited to be a part of the podcast today. And again, I love what I'm doing, coming out, helping people try to figure out the best way, either physical environment or operational environment. And even just as important, I think, guys, is the cultural environment of security in healthcare, because you can have great physical security and you can have great operational security. And if you don't have a culture that coincides with that, you're really wasting your time, because the best lock in the world can't keep somebody from propping it open. And I think we've probably all seen that at one time or another.
I've never seen anything like that, Bryan. That's just, that doesn't happen. People don't prop doors that are supposed to be locked. That's crazy talk.
I've always said if signs worked, I would just put up signs everywhere that said, be nice to each other, and I'd be a farmer and I'd be perfectly happy.
Oh, yeah, signage is an interesting thing. You brought up a couple of things there, Bryan, that I'd like for us to dive into a little bit. And one of the things that I'm very passionate about, and you brought it up, is really understanding, how to present the value of security as an investment for the organization. I like to use the term business enabler. We help the business function effectively. And one of the things that I've seen, recently kind of creep into the conversation around workplace violence is how do we tie workplace violence prevention efforts to positive patient outcomes, or if nothing else, to at least the reduction of negative patient outcomes. And so, those kinds of things, I think, really help us frame that conversation around business enablement or investment versus costs and overhead. You know what I mean? And so
Oh,
I'd be curious your
yeah.
thoughts there.
No, I agree 100%. I've often said if something happened, let's just say a weather event of such magnitude that you would have to evacuate your facility, which nobody wants to have to do that. But after all the patients were gone and all the clinicians were gone, you no longer need food service because there's no one to cook for. Correct? You no longer need environmental because there's nothing to clean up after, so to speak. But guess who's the one that's left there? Security, because you still have to secure the assets and the property in the building. So if you look at it from that point of view, security is a business enabler, because you are literally without security, you have no ability to even keep the lights on, literally, much less when it's occupied and you're dealing with the dynamic nature of patient care and people coming and going and visitors. Not as many lately, I understand that, because of the pandemic, but still, security is such an integral part of the business of just literally keeping things going. It's really astounding sometimes when they are relegated, and I say they, just security in general, when they're relegated to the support services, and it's, oh, that's just another support service. And don't get me wrong, I don't say that in a negative way against anybody else. I think the people that work EVS and environmental services are truly unsung heroes. Same thing for food service. I mean, without these folks doing what they do and doing it really well, we would certainly have disasters. But at the same time, security has to keep the overall function of the business and the organization running, while at the same time responding to dynamic situations that really you can't predict. And I think that's an important part that a lot of people don't think about. With some degree of certainty after time, I can determine how many rooms are going to need to be cleaned today. I can determine how many meal trays are going to have to be put together. I can even look historically, and unless it's something dramatic happens, I can go back and say, my general maintenance cost is going to be this much unless we have something, unexpected happen. But how do you do that with security? Do you know when the next workplace violence event's going to be? I wish we did. Do you know when that next behavioral health patient is going to attempt to elope? Do you know, these are the types of things that we have to be ready for. And Mike, to your point, that's why it's more of a business enabler and an investment, because I'm not trying to tie your security value in, each day by day by day. What I'm doing is I'm looking at what might happen, and I have to have those resources on hand to mitigate that, because the cost of not mitigating it quickly and effectively could be horrible. If somebody misses a meal, they go hungry. If we miss on an event, somebody could get hurt or killed. And I just don't think people put it in those terms all the time.
That's a great point. And I think, we often talk about how sometimes it's hard to prove a negative. It's like we're trying to demonstrate that avoidance factor. But you mentioned it, and I think it's critical in today's security environment and healthcare environment, the retention and turnover values, right? One of the biggest challenges we have in the healthcare market is maintaining enough clinical staff to support our patient loads. And so nurse retention and nurse turnover is a critical discussion, and nurse turnover and nurse retention is a critical component of the benefits of an effective workplace violence prevention program, where your security truly provides an environment in which staff want to come and work because they know healthcare is a dangerous place. And if it's safer at your hospital than the competitor's hospital, well, there's your competitive edge when it comes to retention. Have you seen anything out in the market related to that, where you see organizations utilizing their workplace violence prevention programs as an attraction for staff coming in?
Not so much an attraction as far as a retention tool, and that's something that just recently, in fact, just a few months ago, the I believe it was NSI, the National Healthcare Retention and RN Staffing Report came out. And that indicated not only some of the causality as far as hospital turnover rates when you're talking about clinical, but more importantly, or at least to me, it was what's the average cost of turnover, and it was astronomical. It's not just the hourly rate that you're looking at when you lose a good clinician, especially now, because I think we've all, to your point, Mike, with the turnover rates right now, not only because of the pandemic and because of burnout and, because of all these other things, look at how much some of our clinical counterparts are making being travelers. I mean, it's unbelievable. You could double or even triple your salary by traveling, because that's the market that we're in right now. It truly is a market for, hey, if you're a certified RN or an LPN or whatever the case may be, then you can really make some bank right now. But the fact is, it's not just the turnover of the salary, but you're also going to have to take into place if you have turnover because a person is fearful of their work environment, or because they feel that you don't have adequate security or safety for them, and they go to a competitor or somewhere else. Not only do you have to worry about the cost of that person leaving, but you also are going to have to cover that, because now you have an absence. So you're going to have to cover that with some type of overtime or whatever the case may be. Then you're going to have to onboard someone. Then you're going to have additional benefits. And so it gets very costly. I believe, if I'm not mistaken, in the executive summary of that document, it was in the six figures to replace your typical clinician. And we're not talking about physicians. We're talking about, RNs and LPNs. And I mean, it's unbelievable. Now add to that, to your point, what kind of reputational risk is that going to put the organization in? If suddenly you had a bad event, and they can happen, you can do everything right and things can happen, but if it's not handled appropriately, and if you're not, showing that you are going to have a safe and secure environment moving forward, then the people you're going to lose are probably your better employees. In other words, the people that have a viable alternative to go somewhere else. And I hate to put it in these terms, but the fact is, when things like this happen, your good employees leave. The ones that remain are the ones that don't really have alternatives. Those are your mediocre employees that don't really have another place to go. And so pretty soon it's like all your best people have left, and now you're left with mediocre or worse. And is that really what you want to do when we're talking about a minimal investment to try to make people feel more safe and more secure, and try to get in front of some of these issues before they leave the organization?
I think you're absolutely right. And, you talk about the cost of actual replacement. I've been very interested lately in the actual impact on patient care, because when, to your point, all that's left is the mediocre staff that can't find a better job, or brand new staff that just came out of school, because that's the only replacements you have. What impact does that have on the actual quality of care you're providing your patient? And I think that has far-reaching impacts, not only reputationally for the organization, but in revenue generation when it comes to length of stay and some of those other key components that we see driving a lot of our revenue coming into organizations these days. So I think there's a rabbit hole there that you could continue to go down and really truly demonstrate the tremendous impacts of violence and a violent environment on the quality of patient care, employee retention and turnover, the reputation of the organization, the liability of the organization, all of those things. That those unseen costs are those costs that we don't really have a good handle on or around the industry, are just astronomical, I think, when you put them all together.
I think you're correct. And one of the issues is if somebody were to sit down and really, as you said, follow that trail, pull that string, you're looking at the direct impacts of, let's say you had a workplace violence event because of a lack of adequate security, let's just put it that way, without going into the details. Not only do you have the upfront tangible costs, Mike, as you said, like workman's comp and indemnification and things like that, but then when you start losing those good people, and then patient care is impacted, we're not talking about things like, theoretical, oh, well, our patient care scores may go down. No, we're talking about things that are really going to hit the pocketbook, right? You're looking at readmission rates going up because, to your point, maybe the staff that you've got are either not as skilled, or if they're having to watch their back because they don't feel safe, how much attention are they really giving to the patient? A lot of that has to do with how safe do they feel. Maybe you don't have as experienced a staff as you said because we're replacing them with people right out of school, or maybe it's someone that's not as accustomed to those types of patient populations. And you're anything from readmission to nosocomial infections and all of these things. I think you could follow that thread. And I'm not saying all of that points back to a lack of security, obviously, but it would be very interesting if someone had the time. I think that would make a great thesis or a great, in-depth white paper to really fill out what the true cost of this is, especially when you could get in front of it. I thought it was really interesting a few years ago, and I'm sure you guys remember, the American Hospital Association, I think it was 2017. They came out with a study showing the cost of workplace violence to healthcare in the United States. And they had millions of dollars in external costs and millions of dollars in internal costs. And they broke it down, and it was a very good document, even though it's a few years old now. But the one thing that really stuck with me is they had all these numbers about internal cost of replacement, workman's comp, indemnification, liability, etc. But the average cost to set up a workplace violence program was $17,500. $17,500 to save millions. I am not a mathematician, and nobody has ever accused me of being one, but I know a good ROI when I see one. You're telling me I can spend $17K and avoid $1 million in potential liability, loss, negligence cases, workman's comp? I'll do that all day, Mike. I'll do it all day.
Hey, you know what? You've got me sold, 100%. It's interesting as we talk about this, and before the podcast we had a quick conversation about this, but let's steer the conversation a little differently, because we could really lay out, I think, an effective case. I think as an industry, we do a poor job of this, being healthcare security leaders kind of across the board. I think we do a poor job of laying out the true value of a security program, an effective security program. But as we think about that, I think between the three of us here, we can lay that value out and we can demonstrate that value well. But in a lot of cases, whether it's at the industry level or at the local hospital level or local healthcare system level, security is not invited to the table to help with putting together plans for a workplace violence program. And they're not invited to the table with the discussions around how to put the best physical security measures in place for a new construction project, or they're not invited to the table for policy development on a host of things that have security implications. What is it about our industry currently that puts up so many barriers to having healthcare security professionals and healthcare security leaders at the table in discussions around things like violence prevention in healthcare, physical design of healthcare facilities, things like that?
That's a really great question. It's something that I've thought about a lot, Mike, and Bryan. You've probably seen similar, in the Canadian provinces as well. I remember, I think it was last year, if I'm not mistaken, there was a large study that came out that was talking about violence in Canada, workplace violence in Canada in healthcare. It came out of the, I'm trying to remember now. I think it was like the Standing Committee of Health, but it was a parliamentary session. It might have been 2 years ago. Anyway, long story short, it came down to, we've got these 9 recommendations to all, healthcare organizations on reducing violence. But when you go in and really look at the report and really pay attention to who was involved in it, there were no healthcare security experts in there. Right. So I'm like, okay, well, I get that you can see the results of what, workplace violence is doing to us. And I appreciate that you're trying to do something about it. But why don't you speak to the people that actually have the day-to-day interactions and understand? Because I think you guys both would agree, theory and practice are two wholly different things. It's not academic to the person that's getting beat up in the ER every other week. Right. This isn't a mental exercise. Let's have a thought exercise on, no, this is happening. So why wouldn't we involve people that are directly involved on what works, what doesn't? Because again, to your point, Mike, I've seen people make some suggestions, and no, number one, I'm happy that they're at least thinking about it, but number two, they have some really unrealistic expectations on things, and that's why I think it would save a lot of time and energy if you just had people involved that could speak to some of the details rather than us expending time and resources on things that clearly are not going to work in a practical way. Another good example, so last year the Facility Guidelines Institute, right, which is huge. I mean, FGI, as far as architecture, this is just an absolute huge. Everybody looks to them as a source of truth, accreditation, regulatory. They are the people to go to when you're talking about guidelines. And IAHSS, we've even partnered with them when it comes to healthcare security designs. But FGI came out with it was open. I don't think they've sent the 2022 out yet. In fact, I'm pretty sure they haven't for healthcare. But revisions to the guidelines, when you look at who is involved in the multidisciplinary committee to make these healthcare updates for 2022, here's the breakdown. And I'm looking right off of the slide here. 20% of those people, now this was 130 plus people. This isn't like there were 10 people that got together. I mean, we're talking, this is a big group, multidisciplinary. We're getting a lot of people in here. 20% were architects, 18% were medical professionals, 16% were from the state level as far as just, healthcare accreditation experts, 13% engineering and facilities, 10% administrators, 8% federal from either CMS or HUD or the VA or et cetera, 7% infection control, including CDC, 4% construction, and 4% interior design. What word did I leave out of that? Security. There was no one, not even a percent. So, and if somebody goes, no, wait a minute, we had one security person. Okay, that sounds great. But then if you dig into it a little more, and this is why it's important, Mike, it really is, and you look at some of the things that they are suggesting in some of the FGI guidelines, and these are for facilities that respond to emergency conditions. So that would include acute care hospitals, particularly emergency departments, including residential care facilities. I'm just going to give you a couple of examples, and you tell me if some hospitals will have difficulty in meeting this. And I'm not talking about the big urban hospitals. I'm thinking about the smaller hospitals that are out there on their own, right? For example, this is the proposed language. The emergency department shall be designed to ensure that access control can be maintained at all times. Okay, that's fair. Some places don't do it, but they should do it. And I'm completely on board with that. I think you should have the ability to restrict access in your emergency department when you need to do that, right? Here's the next. A means to detect weapons such as a metal detector shall be provided at each point of entry to the emergency department. Do you see a problem with realistically having every hospital invest not only in the equipment, but also in the FTEs and other support to make that happen? And again, think about this. It doesn't say maybe, it says shall be, and it says at each point of entry. Do you know how many doors lead into an ED? I know you do.
That's an astronomical cost. Yeah.
Yeah, absolutely.
Oh, it's unbelievable. And how is that going to impact your patient scores? And how is that going to impact your potentials like EMTALA? Because let's face it, if everybody's waiting in line to be screened and you don't have appropriate triage watching the line and somebody's having chest pains and they're fourth back in line, then guess what? You've just had a delay of care. You've just had a delay of care that's based on a security standard because you didn't appropriately resource somebody to be out there watching the line to make sure there wasn't a genuine medical emergency standing in line to be screened. I'm just saying the devil's in the details, guys. And why wouldn't they have somebody from healthcare security in this group to say, you know what, that sounds great on paper. It does. Yeah, that sounds great in theory, but do you realize some of the daily challenges we're going to have in implementing any kind of screening at each and every door to the ED 24/7? Yeah, how are you going to do that? So these are the kinds of things that I'm talking about that, number one, we're not being invited, but then number two, and I think this is just as important, are we doing as good a job as we can do as healthcare security professionals in making sure that our fellow directors and AVPs and leaders even know about things like this? And I think that that's something that's on us. I think we do a great job as an industry in sharing information. We're one of the best, I think, of anyone as far as, hey, I've got a policy. You need a policy? Here you go. You can have it. Hey, I figured out a way to do this better than anyone else. Here you go. And I mean, the proof of that is this podcast that we're doing right now. Let's face it. A lot of industries don't clearly share information with one another for one reason or another. But in healthcare security, we're all fighting the same fight. And I think that we do an excellent job in sharing information. So by the same token, then why aren't we invited to share our knowledge and expertise when people are talking about security measures? They should speak to the people that know the most about them. And I'll get off my soapbox now. Sorry, I get kind of passionate about that kind of thing. But why are you doing all these things and you're not asking the people that could really answer the question for you?
And I'll start off by saying, Bryan, you're welcome to jump on your soapbox and stay on it for as long as you want to at any time when you're talking to us. That's not a problem at all. But I guess I want to kind of circle back to that point there and some of the things that you've seen that have been helpful for security leaders in really demonstrating the value that they bring to the table and having some success in being more engaged in those conversations.
I think one of the biggest things, Bryan, is when a security leader really stays on top of the industry. And don't get me wrong, I know, hey, trust me, I did decades of this. It's very challenging, to say the least, when you have an incredibly busy day job and you're just working all the time, just trying to keep the wheels on, right? Trying to keep things going. However, I think that if you are really going to be a leader in the industry, then you have to allot a certain amount of time to keep track of trends and things that are happening. And if nothing else, learn from others' mistakes. I've said that a lot of times. The best mistakes to learn from is somebody else's. I hate that this happened to XYZ, but if it happened there and then I can look at that as lessons learned, then I can come back to my organization and my leadership and say, listen, this incident happened at this other hospital in another part of the country. And I have no indications that that's going to happen here. However, because it has happened there, I think that we should take a look at this and consider what we might do to better prepare and invest in the proper security countermeasures so that if we can't prevent it, at least we can mitigate the impacts of it right away. I think that it's incumbent that we as security leaders do that so that we are up to date on the latest legislation that might impact us as an industry. Things like the new HR 1195 bill in the U.S. That's huge. And Mike, I've seen you speak about it. I've spoken about it. I've talked to a lot of people about it, and the people that really should probably know more about it than I do, a lot of times they just look at me like, well, what is that? And that's not the answer I was looking for. Clearly, one of the biggest parts, quite honestly, to me, that concerns me about 1195 as it is written today. And we all know how bills change when it's trying to be approved. But and I'm just going to give you a quick quote. And this is from section E and F of that document. And for the listeners out there, hey, do yourself a favor, take the time, do a search. It's HR Bill 1195. It's workplace violence prevention for healthcare. But let me just give you these two quick sentences. All training shall provide such employees opportunity to ask questions, give feedback on training, and request additional instruction, clarification, or other follow-up. And what that means is all workplace violence related training. And this is just a portion. But now here's the punchline. Get this, section F. All training shall be provided in person and by an individual with knowledge of workplace violence prevention and of the workplace violence plan, except that any annual training provided to an employee after the first year may be conducted by live video if in person is impractical. Now, take a minute and wrap your head around that. Take the pandemic out of it. Even if we never had the pandemic to deal with, do you know how difficult it is to get people in seats with staffing the way it is to talk to them about something like workplace violence? Because let's face it, not everybody wants to sit in an hour or 30 minutes or whatever you can get. So even if you can somehow figure out how to do that, and you can get them in and get this training done annually, it's not going to be just your LMS module anymore where you can go in and just check the box and, oh yeah, I watched a 15-minute PowerPoint and I answered 5 questions and I'm good to go. If this bill is passed, you will have to have either in-person or live video training annually for the employees. Now think about the cost associated with that. Again, that sounds great on paper. It does. Man, I'm all for that. But if you're a hospital administrator and you're already bogged down by clinical staffing issues and you literally can't put enough people on the floor to keep your ratios right and your patient care is starting to decline, how on earth are you going to afford to send people to don't get me wrong, a very important class, but how are you going to be able to do that? This is what I mean by, as leaders, we need to be more involved in these things and say, that sounds great. However, let's look at an alternative and do it this way. And I think that's the value, back to what we talked about earlier, Mike, the value that we can bring is the practicality of experience to say, what you're suggesting sounds great. However, it is probably going to be more feasible to consider doing it this way.
You know, Bryan, when I look at things like HR 1195, and a lot of the state legislation that have come out in various states related to workplace violence in healthcare, one of the things that I am immediately struck by is that bills like that are a direct result of our failure to govern ourselves effectively as an industry. And so, we're in a position where, the federal government's trying to lay out a law that pushes OSHA to provide guidelines to more strictly control what healthcare organizations are doing because they're not doing it. And because people are being adversely affected by that, both our patients and our employees. And so it really does strike me when you look at, new regulations or additional regulations, the propagation of the workplace violence standards that Joint Commission put out this year and started surveying on this year, I think is another symptom of this inability of our industry to effectively address a problem. And we've just got this kind of head in the sand mentality about it in some cases. And don't get me wrong, there are organizations that are really doing amazing work around workplace violence prevention. But as an industry, we still seem to have this significant barrier to moving forward. And it's almost as if we're going to make your regulators make us do it. Instead of taking ownership ourselves.
No, I agree. I know exactly what you mean. And I think one of the causes of this, and this is a very complex issue and it can't be solved with one or two things, but I think one of the underlying issues is what we discussed earlier in the podcast, Mike and Brine, and that is, how do administrators in healthcare organizations view security? Do they view them as a business enabler and an investment? Or is it a cost center that they are not recouping anything on? And again, if they never speak to security, if security is never invited to the table, if they are never given the opportunity to articulate the value proposition of security and the cost avoidance and the risk management and the ESRM, how then is that administrator, how do they know? I mean, again, how do they know what it is we do if we're not allowed to explain what it is we do? Does that make sense? And to that point, I mean, think about it in these terms. If you're standing side by side with someone from imaging and you both have an ask and you go to a hospital administrator and the imaging person wants a new MRI machine and they say it's going to be this much up front, but the ROI is going to be this much in diagnostics over the next X number of years. And let's face it, MRIs print money. We know that, right? In healthcare, MRIs, I mean, that is one of those, you're going to recoup your investment on it very quickly just because of how much MRIs and charges are. And then you as the security person are standing there and you're asking, I need new video and new access controls because it's not adequate to do what we need to do, but you do not have all of your numbers Who do you think is going to win that round of, I've got X amount of resources to give away? That's where I think we can do the most in helping each other out. Because if one of us has successfully shown how to validate something like that, then that should be shared with all of us. And then all of us benefit. And what's the old saying, a rising tide, all ships go up, right? I think we all better. And I think we've done a good job, but I think we need to do a better job about how we approach things like that. But I agree with you, Mike. I think one of the reasons that we are in the place we are and why we're being forced, to do the regulations, kind of like the military, right? OSHA can't make you do it. They make you wish you'd done it. I can tell you that. But the fact of the matter is, the reason that we're in that place is I don't feel that our own organizations understand the true value and impact that a good, solid security program can provide them. I really don't think they do.
I think you're 100% right, Brian. I'll tell you, when I get the opportunity to mentor people, young men who want to be leaders in healthcare security or coming up in the organizations, looking to what it might be to move into a managerial role, I always tell them across the board, you don't need a degree in criminal justice. What you need to do is go get a degree in business so you can speak that language effectively, because it is through our ability to articulate investment and return on investment that we can gain the most ground in moving, our projects, initiatives, plans, and things like that forward for healthcare security.
That's exactly right. If you are a modern healthcare security leader and you do not know how to put a business case together and you do not know how to do an SBAR, then you need to learn that immediately. You are absolutely right, because there are two types of audiences, I guess is the best way to put it. When you have a request, in my opinion, when you have a request, when I'm talking about security and safety and EM, you have the people that appreciate numbers and the people that appreciate the narrative. And some people and this is just my experience, I'm not trying to paint anyone with a broad brush, but in my experience, certain departments, certain units, certain people in direct patient care appreciate a narrative story more with just a few numbers. And by that, I mean, you come in and tell them the story, explain to them what you're using these security resources for. It could be FTEs, could be video, could be access, could be whatever the case is, but explain how in a narrative story that's going to impact them. And then the numbers to them are secondary. Then you've got to go to your CFOs and COOs and the people where the numbers are the primary, and you need to be able to speak their language and talk about ROIs and SBARs and investments and what differentiates this ask from that. And then the narrative to them is secondary. And I think if you can blend those two things and be able to quickly turn from narrative to numbers and back and forth, then you will be much more successful.
100% agree. I think you're absolutely right. And I think it really is incumbent upon us to understand our responsibility in that process, not to get stuck on this idea that it's their responsibility to understand us as much as it's our responsibility to communicate effectively. That's a great point.
I agree. One thing that I always told my managers, and I still tell my clients today, is even your supervisors, whatever your hierarchy is in departments, they have as many different programs as you can imagine. Everybody calls things, but if you have somebody in a leadership position, each one of your leaders should have that 30-second elevator speech ready to go. And by that, I mean, they should be able to articulate very quickly what's going on in your department, and in a very well done professional manner, because you never know when you're going to be sharing that elevator with the COO or the COO or the CFO. And by that, I mean, you get on the elevator and your CEO's on the elevator and they go, "So how are things going in security?" And you go, "They're fine." You just missed an opportunity. But if that CEO gets on the elevator and you're on the elevator and you weren't expecting it and you're just going to get something to drink or whatever, and they go, "How are things going in security?" And your response is something like, "Well, sir, it's going," or "Ma'am, everything's going great, with the workplace violence rate right now of about 10.4 per 10,000, which is 5 times greater than any other industry in the country. And the fact that we're looking at indemnification and workplace violence costs as a tangible and intangible impact on our ability to provide excellent patient care, I think we're doing okay, but I would certainly appreciate the opportunity to talk about some of the additional resources that might help invest to not only protect our staff, but to also provide better patient care and better outcomes. That's about 20 seconds worth. And do you think they're going to get off the elevator thinking, well, that guy's stupid? No, they're going to get off the elevator and go, interesting. Or at least that's the way I would hope that they would. Now, I'm not going to say have that script in your pocket and whip it out, because, you can't be disingenuous. It's not like, whipping out the card and reading the person their Miranda rights, right? Every individual, every person has to have their own script that makes sense for them. I don't expect a line supervisor on night shift to go into that level of detail about industry, but that line supervisor should know some of the specific things that they can speak intelligently on that will make an impact with that administrator. So that administrator will then follow up and ask somebody, hey, I got on the elevator the other night and the night shift supervisor with security said some interesting things. Can you follow up on that? That is where you get your foot in the door, Mike. And that is how you can start to get from the basement to the boardroom, as we always say. And I think that it's critical that anybody in a leadership position be able to do that and be able to talk about the current state of the organization, and even larger if they get the opportunity to do so.
That's some great stuff, Bryan. I'm really excited that we've had the opportunity to have this conversation. And I genuinely hope that the people that are listening to this conversation can garner some opportunities from it in the way we approach how we talk about security work, its investment opportunity for the organization, and how we articulate more effectively our return on investment to the organization as a whole. So that's great stuff, man. I appreciate it.
No, I appreciate the opportunity to talk about it. Again, I'm very passionate about it. You can tell, man, I get fired up when I talk about this. And I think one of the reasons why is we're just missing out on so much. And we have pockets of good practice. I guess that's the way I would describe it. We have pockets of good practice across the world, not just the US, but in Canada and other. We have pockets of good practice, but at the same time, we have opportunities for improvement. And I think if we did a better job in spreading those pockets of good practice, we could take care of a lot of those opportunities for improvement, just by virtue of sharing information and then by helping each other out. And I think we've done a great job, but that's where things like associations and professional affiliations and really getting out there, doing webinars, writing articles, putting together information in things. Shout out to Bryan. I know he won't take credit for it. He just finished authoring a textbook about security. Again, that's the sharing of knowledge and sharing of information, because if we do that, we get so much back in return. And I think as an industry, it benefits everyone. So I think we've done a really good job. I would just stress, let's continue to do a good job and help each other out whenever we can.
Thank you, Bryan, for that mention. And again, thank you for taking the time today. Now, when you talk about putting the narrative and the numbers together, Bryan's definitely a guy who's really great at doing that. So, a great model to follow there. Again, Bryan, thank you for taking the time. And until next time, folks, stay proactive.